The next topic will be pressors and shock papers that we should all know. What pressors, what dose, when to add steroids, what should be the MAP target, what are the top 10 articles that we should know. So the first study is the SOAP2 study. This is from New England Journal of Medicine 2010. 1679 patients across 8 centers, all-cause shock, 62% septic, 17% cardiogenic. Dopamine versus norepinephrine as first-line vasopressor to maintain a MAP greater than 65. So they looked at 28-day mortality. You can see here it was 52.5% versus 48.5%. First of all, that's a pretty high mortality, right? So that's one thing you could see, but the primary outcome was technically neutral. You could also see the arrhythmias, 12.4% versus dopamine. This is the secondary data, which was fascinating. Drug discontinuation happened in 6% of the patients with dopamine and only 1.6% with Levophed. Cardiogenic shock, the subgroup, dopamine did significantly worse, surprisingly. So Levophed is first line, full stop. Dopamine is arrhythmogenic and harmful in cardiogenic shock. It's retired basically, except for, as you know, in the BLS and ACLS protocols for symptomatic bradycardia, second line, after atropine. Paper number 2 here, VASST trial, Russell, New England Journal of Medicine 2008. So 778 patients with septic shock already on catecholamines. So we're looking at low dose vasopressin 0.03 to 0.01 to 0.03 units per minute versus norepinephrine as a blinded add-on. The overall 28-day mortality was 35.4% versus 39.3%, so it's neutral. What was interesting is the pre-specified less severe shock subgroup. You can see here vasopressin was 26.5% versus norepinephrine 35.7%. That was a meaningful signal, and the adverse events were identical across both arms, safe. The message really is add vasopressin early to spare your Levophed dose, especially in less severe shock. You shouldn't swap it for norepinephrine, but it's an adjunct. SEPSISPAM trial in New England Journal of Medicine 2014, 776 patients, MAP target 65 to 70 versus 80 to 85 for the first 5 days. You can see here on the graphic that the 28-day mortality was not different, 34% versus 36.6%, but the higher MAPs, with higher MAPs targeted, they had more atrial fibrillation, 6.7% versus 2.7%. P was 0.02. The one exception, and this matters, was the pre-specified chronic kidney disease subgroup. Higher MAP targeted reduced the need for RRT, 31% versus 42%, with a p-value of 0.04. So MAP 65 is basically your target for most patients. Pushing a higher MAP just causes atrial fibrillation and wastes norepinephrine. However, in chronic kidney disease patients, consider 75 to 80 to protect the kidneys. The next trial, CENSER trial in 2019, it was in chest, 310 patients in the emergency room, septic shock. Early norepinephrine within an hour of shock criteria versus standard care. Shock control at 6 hours was 76.1% versus 48.4%. That was a massive practical difference. Less fluid in the norepinephrine arm, 1.2 liters less in the first 24 hours. And you could think of this as the precursor to the Clovers trial. Cardiogenic pulmonary edema, 4% versus 10.9%. Less fluid, less flash pulmonary edema. ICU, 3 days, significantly better. 28-day mortality trended lower, 15 versus 22%. But the trial was underpowered. The message is simple. Start norepinephrine early. Don't wait for the fluid bolus to finish. Early pressors give you better shock control, less fluid overload. JAMA in 2016, the VANISH trial, So now we're looking at 409 patients, 18 UK ICUs. It was a 2x2 factorial design, vasopressin versus norepinephrine, each with or without hydrocortisone. The primary outcome was kidney failure, 3 days. And you can see here there was no difference across all arms. 28-day mortality, 31 or 30.9%, and vasopressin versus 27.5%. Norepinephrine was neutral. But the secondary outcome, the vasopressin arm needed less RRT. It's 25.4% versus 35.3%, p-value of 0.05. Hydrocortisone alone, there was no renal benefit, caused more hypoglycemia, hypernatremia. So the vasopressin doesn't save lives, but it may spare the kidneys from renal replacement therapy, was the takeaway message from the VANISH trial. We already saw the VASST trial where it looked at less severe septic shock. Steroids alone do not add renal benefit, and the classic trial design here was 2x2 matrix, which is sort of interesting. The next trial to know is the ATHOS-3, New England Journal of Medicine 2017, 344 patients, catecholamine refractory vasodilatory shock. I believe the trade name is called Gioprezza. High-dose pressors, Apache 2 around 32. This is the sickest of the sick. Angiotensin II versus placebo on top of existing vasopressors. The MAP response at 3 hours is what they looked at, and the primary outcome was 69.9% versus 23.4%. So it definitely works. The norepinephrine equivalent dose went down in the angiotensin II arm, and it went up in the placebo. 28-day mortality was 46 versus 54%. There was a trend, but it wasn't powered for mortality. AKI on RRT subgroup, maybe there was a mortality benefit, 54 versus 65%. The FDA approved it in 2017 as a rescue pressor. We rarely use it, Gioprezza, but really you think of when you're maxed out on catecholamines, it's a legitimate next step, especially if they're on renal replacement therapy. The next two trials to discuss are the ADRENAL trial and the APROCCHSS trial. So the ADRENAL is the largest steroid trial ever. It was 3,658 patients. You can see here 69 ICUs globally, septic shock on mechanical ventilation, hydrocortisone 200 milligrams a day continuous, infusion for 7 days versus placebo. Remember, the first ARDS trial was also a continuous infusion, wasn't bolus steroids, and that was a positive trial. But this 90-day mortality was not impressively different, 27.9 versus 28.8%, but there were clinically meaningful secondary outcomes. Vasopressor discontinuation, 3 days versus 4 days, shorter ICU stay, 10 versus 12 days, and less transfusion, 37 versus 41%. No increase in superinfection, GI bleed, hyperglycemia. So why didn't the ADRENAL show a mortality benefit? As you'll see, the APROCCHSS trial did show. We'll look at that. But hydrocortisone definitely alone speeds shock reversal, but doesn't reduce mortality. The combination is what matters. Now, the APROCCHSS trial, also in the same journal, New England Journal of Medicine 2018 by Anane et al., 1,241 patients, 34 French ICUs, septic shock on vasopressors and mechanical ventilation. Again, hydrocortisone 200 milligrams a day, but this time they added fludrocortisone 50 micrograms a day for 7 days. And 90-day mortality was looked at, 43% versus 49.1%, p-value 0.03. NNT was approximately 16. It's a real mortality benefit. ICU mortality, you could see, is 35.4% versus 41.0%, which was a p-value of 0.04. Faster vasopressor discontinuation, no increases in infections. The difference from the ADRENAL was really fludrocortisone, and it covers the mineralocorticoid axis, which hydrocortisone misses at the physiologic doses. So it's the combination that wins. So very often we're using hydrocortisone in the ICU and not using the fludrocortisone. Remember, the APROCCHSS trial added both. So you should add fludrocortisone to the hydrocortisone in refractory septic shock, and the NNT, remember, is 16. The next papers to discuss really are the epinephrine and norepinephrine papers. So both the Lancet 2007 article by Anani looking at epinephrine versus norepinephrine, and the Morelli Critical Care 2008 trial. So, vasopressin, angiotensin II get a spotlight, but in the operating room, the two pressors that are actually reached for are usually epinephrine and phenylephrine. So we'll look at that. Epinephrine versus norepinephrine. The Lancet 2007 Anani trial, 330 patients with septic shock randomized to epi alone or norepinephrine plus dobutamine if needed. The time to shock resolution, there was really no difference. 28-day mortality, no difference, roughly 40%. But epinephrine caused transient hyperlactemia and metabolic acidosis. That's the direct beta-2 mediated effect on lactate production, not tissue hyperperfusion. If your patient's on epinephrine, remember that lactic acid is unreliable as a resuscitation endpoint for the first 24 hours. So, but what about phenylephrine versus norepinephrine? So by the way, before I go on, it's not that epinephrine was inferior to norepinephrine, it was just as beneficial, so there was really no difference. But now phenylephrine versus norepinephrine, it's small, but there was only 32 patients in septic shock randomized head-to-head. Both drugs restored the MAP and systemic hemodynamics comparably. There was no significant difference in splanchnic perfusion markers when phenylephrine was started early. But here's what matters most. The Surviving Sepsis Campaign explicitly recommends against phenylephrine as a first-line vasopressor in septic shock. There's a concern for reduced splanchnic blood flow, no inotropic effect, some reflex bradycardia that could limit your cardiac output. And remember, it's a pure alpha-1 agonist, no increased heart rate. And so when would you use the phenylephrine? Perioperatively or hypotension, maybe anesthesia-induced hypotension, right after you intubate. Short bridging boluses, but not as the septic shock workhorse like we think of vasopressin and levofed. So epinephrine can cause lactate confusion, not necessarily harm. Phenylephrine is fine for the operating room and peri-intubation, but it's not usually the first line for septic ICU patients. Also for the boards, you should know, of course, tachycardia. If you have somebody who's already with a heart rate of 150 on in atrial fibrillation, that's usually the pressor that we use. And the last thing to know is the Surviving Sepsis Campaign guidelines. 2021 is the last guideline rendition. And norepinephrine's first line. Add vasopressin when the levofed is getting up there. Typically, we think of 15 mics is already. You want to do it before you go over 15 mics per minute. Epinephrine is a salvage only. Dopamine is not recommended. MAP target greater than 65, and you titrate to endpoints, which would be lactate clearance. Remember, 20% at 2 hours or 10% at 1 hour. Or you think cap refill time. Cap refill time at 3 seconds. Updated 2026 to reflect the Andromeda 2 trial. The 1 hour bundle is cultures antibiotics, 30 cc's per kilogram. Fluid vasopressors if the MAP is less than 65 despite fluids, and then you remeasure the lactic acid. Honorable mentions, Clovers we discussed in the fluid section. That's early norepinephrine plus restricted fluids versus liberal. It was identical 90-day mortality. It confirmed the safety of early vasopressor use. And also the studies of Arishi et al., Journal of Critical Care, 2023, looking at norepinephrine plus phenylephrine versus norepinephrine plus vasopressin. It was a retrospective cohort, 287 patients, no significant mortality difference between phenylephrine and vasopressin, a second-line add-on to norepinephrine. So it is a reasonable second-line option. If you look at the data from the New York Sepsis review, there was an increase in mortality when they ran out of levofed and they used phenylephrine. So people are usually shy away from phenylephrine for septic shock, and I would personally use vasopressin over phenylephrine. In New England Journal of Medicine 2001, there was a famous Zyger's trial, the PROWESS trial. Activated protein C showed an early mortality benefit. That's not really a pressor, we don't think of it, but it is good to note that it was not reproduced in the PROWESS shock trial about 11 years later, and the drug was withdrawn. But it is a classic teaching case because it had exciting early data. You shouldn't jump to the early positive trials because it had a negative replication, but it was food for thought. Not really as a pressor, but definitely one to remember. So in short, start Levophed early, add vasopressin, spare the dose, target map 65. These are the 10 key articles to know. Combination steroid regimen, fludrocortisone, add to hydrocortisone, the adrenal APROCCHSS trial, and think about epinephrine and phenylephrine more second line in this particular population.